This is my client with the very rigid pelvis. And it might be rather subtle. Go ahead and turn around and come back. And just repeat a couple of times. But I think it's pretty easy to see that she doesn't have any transverse plane motion in her pelvis. Do you usually walk faster than this?
I do.
Uh-huh.
I walk fast.
Okay, alrighty. Well, let's have you come lie on your back on the table.
Okay.
And I'll focus on the summary of findings with respect to your pelvis, and then T3, 4, and upper cervical. So lying on your back, you had excellent hip range of motion on both sides. And the pelvis is extremely rigid. I'm putting 15 pounds of force, which is normal. And we should see some movement where I can take up the slack in this structure. There's no give at all. And so now I'm putting 30 pounds of force and nothing's giving. Here is a side glide movement. And I just can't even take up the slack. I'm putting plenty of force that would induce movement in someone without this pattern. And the pattern that you have is that in one of your falls, I understand you had 2 falls.
Yes.
You can lie on your stomach. In one of your falls, when you land on your sit bones, it gaps the sacroiliac joint and your body hyperflexes, and it seems that that is what drives the sacrum posteriorly. I see this pattern in people who have had a fall or who've delivered a very large baby. And your babies weren't that large, right?
No.
Okay. So let me move my camera. And so Betty's lying on her stomach. And the sacrum appears to be very posterior. My thumb is on the PSIS, which is much deeper than the S2 segment. And my right thumb is now on her right PSIS. And maybe it's not the best camera angle, but this sacrum is distinctly posterior in relationship to the right PSIS. And usually you fall off the PSIS into what's called a sacral sulcus. Now if I try and spring the sacrum, there's no give with a reasonable amount of force. And that's true for inferior glide movement. And that's true for superior glide movement. This feels like a block of granite. This is the sacrotuberous ligament here. And it feels ropey, except it has no give. It feels like bone. Because that sacrum is posterior, then these ligaments become very, very tight, the sacrospinous and the sacrotuberous. We did find a slight restriction of left hip extension. We found a little bit of asymmetry in the pelvis from side to side. So there could be, another pattern of rotation going on, but with all motion blocked, it's really hard to discern that. And what I have found is that when someone presents with a posterior sacral wedging, not only do they lose movement in their pelvis, but this shifts the center of mass posteriorly such that the body has to compensate. And the body compensates reflexively by creating hyperextension at about T3, 4, including the third rib, in which spring testing reveals a similar pattern here, a loss of movement. And that's also true for the upper body of the sternum. And it's also true for the occipito-atlantal junction. But what I want to do before I move up there is demonstrate L5. And we tested her earlier, and L5 is right here. There's a convenient landmark there. And I'm pushing with 10 pounds of force, and I can't take up the slack, and I'm going into about 15, and that's plenty, and I'm not going to go further. And then I get on L4, and you'll notice that I can sink in. I can move it and take up the slack, and then I can spring, and there's forward movement and recoil. Okay, so I'll change the camera to show the upper thoracic. So I'm able to take up the slack and spring, and I'm probably at about T6, and then that might be T5, this might be T4, and then we get up on what I believe to be T3, and there's no give. We can spring the ribs, and right here this rib does not spring. Okay? Let's have you roll onto your back, please. So I'm springing the body of the sternum, and there's normative spring, and right when we get to that upper body, there's a lack of spring mobility. And this will resolve when I correct the sacral mobility and the pelvic mobility in general. And what I'm going to do now is demonstrate the rigidity in the upper cervical spine. I can't film the whole body there, but typically when I do traction, when you apply the force of traction on both sides on the temples, you should see movement all the way down the body into the toes, and I'm contacting it with this part of my hand, and this is so rigid I can't induce any movement. And if I try and lift her head up towards the ceiling, it's extremely, I'm going to use the word heavy, and that's because the first joint, the occipito-atlantal joint, is very, very rigid. In fact, if I try and spring your spring your mastoid, which is part of the temple actually, if I try to spring the mastoid, there's no give, no give. If I try and side bend at the mastoid, there's no give, no give. And if I try and spring C1 on either side, it's extremely rigid. Now I come down to C2, and you can see her whole neck moves. Now if I, again, try and lift her up at C1, the head is just locked. But if I come down to C2 on 3, boom, I can lift that head up very freely. So again, no traction here. And this is a reflex phenomenon such that when we free up mobility in your pelvis, the rigidity at the sternum in T3 and the rib and the rigidity up here in the upper cervical spine should melt reflexively. Now if it doesn't, then we know what to do for it. But chances are very good it'll just soften up on its own.
Okay.
So, thank you for letting me film that. And
No
I'll
problem.
download it and put it on your flash drive.
Okay.
I'll actually